While you'll argue to save time, I'll just continue because I am carrying coals to Newcastle over here. So I don't have to give any tips to this audience, but for the benefit of the projectionist, you might learn a little bit. So the options that we have in infective keratitis, surgical options are surgical debridement, AC wash if it's a fungal with M4. You can use tissue adhesives, you can use amniotic membranes. These are things, surgical things which have been tried. Of course, prevention is better than cure, which is said by everybody. So if there is an ulcer with imminent perforation, treat it as an emergency. If perforation occurs, restore the integrity ASAP by tissue adhesives is small, patch graft if peripheral, and AMT. And if you have tissue available, then of course penetrating keratoplasty, which will restore the structural integrity. It will resolve a refractory, if just nothing is working, at least you get rid of the load, reduce the organisms in the cornea to a manageable level. And if it's a central ulcer which is not healing, then you can even use an optical grade tissue if you get it, and it might be just a single time graft that you have to do. So it's an emergency. Why? Because perforation will increase the chances of end-off. Central corneal infections, as I said, you can get optical results. And if infection is not controlled, it might go on to the sclera, in which case it becomes extremely difficult to treat. The pre-op, of course, depending on what the scraping has shown, we will put the patient on topical antibiotics or antifungals. If possible, you can do a gentle B scan to rule out choroidal detachment. I prefer a general anesthesia when the patient is fit. Give realistic prognosis and keep the microbiology lab on alert. Donor material, in emergency, we use whatever is available. If it's a central graft, good donor is always better, and I keep large trifines ready. You don't really know how large the donor is going to be, so you trifine the recipient first. Trephination in the recipient has difficulties. Hypotony makes trephination difficult, and therefore you might go too deep and injure the iris during the trephination. That is quite possible. And then even if you've just made the cut, we recommend obviously that you don't go full thickness through, just make a nice deep groove and then enter with a knife. But even cutting with scissors difficult, the corneal opacification hinders the view, and UVR lens, IOL often come bulging forward. Vitreous may be adherent to cornea if it's an aphakic eye, so you need to cut very gently. So I normally mark the area with the trifine, cut with scissors. If there is already a perforation, start at the perforation site and then follow the groove. Use copious amounts of viscoelastic, cut the recipient cornea first, and peripheral iridectomy is essential. If the fistula is small, I will close with glue and then go ahead with trephination. Try and reform the chamber, use a good speculum. If the eye is soft, use a Fleringa ring. In fact, in all TPKs, it's good to use a Fleringa ring to prevent prolapse and the scleral prolapse, scleral collapse, and expulsive hemorrhage. And if you have access to Hesburg-Barron, that would be ideal, but otherwise just use whatever you have. After the recipient button is removed, inspect the AC for peripheral synechiae, posterior synechiae, cataracts. Look for inflammatory membrane. This is important that you, many a time in all these cases, there is a thin inflammatory membrane over the iris, and unless you look for it and sort of dig it out from there, you will leave behind a sort of a membrane over there, and the inflammation will continue. If possible, don't remove the cataract at the same sitting, because you get increased risk of expulsive hemorrhage, vitreous loss, endophthalmitis, and you can have P. acnes or whatever organism getting sequestered in the bag. So if you can, please do it at the second sitting. And you normally tell the patient that you will require a second optical sitting. At that time, you can do the cataract surgery. After the recipient button is removed, irrigate the AC to remove the necrotic debris. Place copious viscoelastics in the angle. Try and open all the peripheral synechiae if possible. And I take at least 16 interrupted sutures, always interrupted sutures. 10-0 nylon, 75% depth. In a regular optical keratoplasty, you can go up to 90% depth. But in this, it is difficult, so 75% depth is quite adequate. Moderate amount of suture tension. Go further into the recipient bed to avoid cheese wiring. Reform the AC. Check all the synechiae are lysed and check the wound repeatedly for leaks. You can put fluorescein drop also if you like. If you're giving a subconjunctival in an antibiotic, in a the bacterial infection, you can give an antibiotic. Avoid a subconjunctival depot steroid if fungus is suspected. And if it's a small central ulcer completely removed, then you can of course give subconjunctival steroid.
VLC में play करो from the folder.
Yes, sir. It's disconnecting by itself actually.
No, if the folder is there on which the video is there, you can play the video
Yes, sir.
separately.
No, the pen drive disconnected by itself actually.
This is playing, it's not here.
Oh, it's not here. Audio issue. Audio issue.
One second. I've forgotten how to do this.
सर ऑडियो है उसके अंदर
हाँ जी,
ऑडियो चाहिए
ऑडियो नहीं चाहिए इसमें. One second. Now it will work. गया.
Yeah.
Pen drive isn't showing now.
You can put this directly into this.
No sir,
Achha.
it doesn't have USB ports. It's connecting. It will take because the presentation also.
Actually, the video was embedded in it.
It's here. We can play it later, I guess, when it detects it.
Yeah.
Yes, sir.
Playing?
Media not found.
Play it from the.
I'll connect it here. Should not happen, so normally works.
Okay. We'll go on with the PowerPoint and close.
Yes, sir. Well, if it, yeah, it's come. I only have quick time. No, it won't work, sir.
Okay, let's just go ahead with the. Okay, so we'll just pretend that you all have seen a fantastic video of the therapeutic penetrating keratoplasty. Thank you so much. The common post-op complications are secondary glaucoma. We need to look at graft failure first in the first 1 month, and later on, of course, graft rejection and infection in the graft itself, which is commoner in fungal cases. Prognosis depends, of course, on the type and virulence of the organism and the type of treatment that you give post-surgery. Post-surgical care is challenging. When do you give steroids? So you can give steroids immediately after if you think you've removed almost all the bacterial. If it's fungal, I at least wait for about 3 to 4 weeks. Acanthamoeba also at least wait for about a month and put the patient on fortified topical whatever drug depending on your lab reports. If the sclera is involved, IV antibiotics, otherwise not required. Anti-glaucoma treatment prophylactically, and then as soon as possible measure the pressure. I use an eye care tonometer by which you can measure from the next day itself. So thank you so much for your attention.
Sir, I have one question. Like, so a lot of times what happens in therapeutic is the lens is bulging out.
Yeah.
So, would you recommend doing a pars plana vitrectomy at that time, or just?
If you have somebody good who can do a pars plana vitrectomy and bring the bulge down, fine. Otherwise, if you use a Fleringer ring, if you give mannitol pre-op and you use viscoelastics to tamp it down, you can normally get by without having the lens bulging up. But if you can't, and worst case scenario, then a pars plana vitrectomy by somebody who's trained in that, because otherwise you can get an expulsive on table. Yeah. Okay, thank you.